Up next, Richard Conti is joined by Dr. Justin Ezekowitz, Associate Professor and Director of the Heart Function Clinic at the University of Alberta in Edmonton, Canada. They cover providing rapid out-of-hospital acute cardiovascular treatment, the PROACT-4 study.
Justin, why don't you start off by just giving us an overview of this trial? Why did you start it, and what's it all about?
Well, first of all, Dr. Conti, thank you for having me on this program. It's a terrific translation of our research enterprise. So the PROACT trial was really designed out of trying to understand if a point-of-care troponin done in the ambulance by paramedics in patients with chest pain would speed up the care for patients arriving to the ER with chest pain. That was the fundamental question we asked in the beginning, and we did a trial that tried to explore that issue in a very pragmatic way in a large geographic region across a lot of ambulances and all the hospitals in our zone.
So this was all in Edmonton, of all private hospitals, public hospitals, university hospital?
Yeah, so we have about 88 ambulances, about 3,600 square kilometers, where we cover all hospitals, which is 5 hospitals, which are a mixture of university, academic community, 2 PCI centers, and even a standalone ER. And any individual showing up in an ambulance can go to any one of those centers, regardless of where they were initially picked up.
So the patient population is a patient with chest pain, and the intervention was doing a point-of-care troponin level.
Correct. And that's all we did. We essentially had paramedics identify these patients with chest pain, and if they didn't have something such as a asthma or a knife in the chest that could have caused that, they were randomized into the trial after a brief consent, did a point-of-care troponin. Simple as that.
And then they were taken care of by the usual ED physicians, and if they were admitted, they were taken care of in the usual way. Nothing fancy that your trial imposed on the people taking care of the patient.
That's right. So after the ambulance arrived at the ER, we made sure that the troponin result was handed over to the ER physician and staff, and they did whatever they would normally do at every one of those hospitals, which included more troponin testing, chest x-rays, ECGs, you name it. They could have done any one of those. If they were admitted in hospital, we offered no other risk stratification tools whatsoever. So we had a single intervention, which was the point-of-care troponin, handed over to the ER doc, and that's where we let things lie.
Just out of curiosity, how many troponins were positive?
Great question, because I'm just going to bring up the number. So we had approximately, on our point-of-care test, which is 0.03 nanograms per mil, 9.8%. So around 10% had a troponin above a detectable level on a point-of-care troponin test. And that is about right for this population if you look at larger surveys that are cohort studies. This is a randomized trial, so you never know what you're going to get, but around 10% had a point-of-care troponin test that was positive.
So that suggests that many of these people with chest pain certainly didn't have an infarction, or at least they were in such an early stage of their infarction that they weren't releasing any troponin.
Right. In fact, we adjudicated each diagnosis. So of the 601 patients, only 112 had an acute coronary syndrome. And of those, the initial troponins were mostly positive, but not all. So even caught in the early stages, you could really get pretty good at detecting their acute coronary syndrome early on. But you're right, the majority of patients didn't in fact have an acute coronary syndrome in this trial.
So you have to interpret the situation, the context of the situation, not just the troponin level.
Right. As with all good clinical medicine, we're not a single biomarker, and I think that's a critical point of even a point-of-care troponin. Doesn't matter where we test it, it has to be taken in context of the other features of that patient and the situation.
So what were the results?
Our primary endpoint, which I think I just need to explain a little bit, is we calculated the time from when an ambulance arrived on scene, so a patient's home or a condo or mall or whatever that might be, but arrival on scene, which is first medical contact, to final disposition or final patient disposition. That is, in the ER, the decision to either admit or discharge. That's the kind of way we calculated it. Now, overall, we expected that would take, in Canadian context, about 8.8 hours or so, factoring in about 30 minutes of ambulance time or so. And our overall primary outcome was we had a trend towards reducing that time by about 23 minutes. We have looked at this in a lot of different ways, but we reduced the amount of time spent in the emergency department first medical contact to final disposition by about 23 minutes. That takes into account also there was about a 100-minute difference between the two troponins being tested, a point-of-care troponin and a troponin in the ER. So we know there's still some optimization there to be gained. And so as a pragmatic trial, it's a small gain with a simple intervention, and there's lots more to learn.
Another curious question here. How reliable is a point-of-care troponin?
We carefully selected a point-of-care troponin that was approved by Health Canada, both the device and the assay, which is felt to be a conventional sensitivity troponin. So it is pretty good down to the lower levels of troponin. The detection limits versus the 99th percentile are about 0.02. So we are careful to go above that threshold in this trial that we went to 0.03. So it's a conventional troponin. One can imagine that if you used a highly sensitive troponin, that might change the results a little bit, but it's unlikely it would have a dramatic change in the outcomes.
I think that's right. Why would you expect doing a troponin in the ambulance by the first responders would change anything? Help me out with that.
Sure. So we live in an environment where our paramedics are very well trained, and they deliver STEMI care such as lytics or direct to PCI into an angioplasty suite. They deliver stroke care, and there's no reason that they can't test a blood marker and in the future be able to risk stratify on scene, perhaps leave it home, drop off at an urgent care center, or even at an ER, depending on the risk profile of that patient. The first step was really to figure out, does a point of care troponin make any difference? So if we just move that needle up by about 100 minutes or so, could you actually expedite patients through the ER? And in our system, where we're in a cost-constrained system, moving people through the ER is really important because that's an opportunity cost for other patients. So even 100 minutes gain would be great. You know, you can imagine 2 to 3 hours being shaved off here if you sped the system up a lot faster.
Well, I mean, this is important work. I quite frankly don't quite understand why it should make a difference doing troponin in the ED, but I'll take your point. And let me see if I can summarize some of the take-home points that I think are worthwhile. First of all, the troponin in the ambulance shortened the time to decision-making. You agree with that?
I agree.
Okay. Secondly, the majority of patients with chest pain in the ED do not have an acute coronary syndrome.
This is a new area for me, and that was a striking clinical realization of this topic, that there's a lot of people out there with chest pain that don't have a lick of an acute coronary syndrome. We have to realize that in our
I think we want to be careful about talking about acute coronary syndrome as though it's some kind of separate entity. I mean, it's a spectrum of problems, of unstable angina, ST segment elevation myocardial infarction, other myocardial infarctions not associated with ST segment, or maybe even a missed ST segment elevation myocardial infarction. But at any rate, the majority of chest pain patients don't have what we now consider an acute coronary syndrome. And then, of course, the final thing is that you mentioned earlier, all of this information was acquired in a clinical setting, not just a medical school selected group of people. It was all comers. Is that correct?
Yeah, that's correct. I mean, this is a community-based pragmatic trial with, 88 ambulances, 300 paramedics, every hospital, every ER, so lots of different settings, winter, summer, night, daytime, you name it. This is how we did the trial. So it really is meant to be a real scenario.
Anything else you want to add to this?
Well, I would just implore people to think carefully about looking at trials and other research that looks at the ambulance. This is a great area of opportunity, as we've learned in STEMI care and also in cardiac arrest. I think there's lots more to be gained from our excellent colleagues who are paramedics.
Fine. Thank you very much. That about covers it.
Thank you.